The overall goal of this procedure is to produce a mouse model of sepsis by a surgical procedure called cecal ligation and puncture, or CLP. This is accomplished by first making a 1.5 to 2 cm midline incision on the abdomen of a mouse. Next, the cecum is exposed and ligated. Then, the cecum is punctured to induce bacterial translocation. Finally, the incision is closed. Ultimately, results can be obtained that show increases in systemic and peritoneal cytokine levels, as well as symptoms such as lethargy and lethality.
What I'm going to show you is to produce a mouse sepsis model termed cecal ligation and puncture, which is modified from the original model developed by Dr. Chandri and his collaborators. The main advantage of this model is that it is the most relevant model of sepsis. In addition, it's simple, well-characterized, and economically feasible, and therefore has been widely used in the field of sepsis and inflammation research. As an example, we will demonstrate the utilization of this model to evaluate the therapeutic potential of herbal extract in sepsis.
To prepare the herbal extract, soak 10 grams of herbs in 200 milliliters of water at 85 degrees Celsius for 1 to 4 hours. To remove insoluble particles, centrifuge the water fraction at 3,300 G for 20 minutes at 4 degrees Celsius. Next, filter the supernatant through a 0.2 micron filter. Then, further concentrate the filtrate by using a centrifugal filter with a 10,000 kilodalton molecular weight cutoff and spinning at 5,000 G for 60 minutes at 4 degrees Celsius. Using macrophage cultures, screen the low and high molecular weight fractions for inhibiting activities of late pro-inflammatory mediators such as high mobility group box 1 or HMGB1. To begin macrophage isolation, first intraperitoneally administer 2 milliliters of a 4% thioglycolate broth into normal mice. After 3 days, harvest primary peritoneal macrophages. Culture the macrophages in DMEM supplemented with 10% FBS, 2 millimolar glutamine, and 1% penicillin streptomycin. Gently wash the adherent macrophages with Optimem and incubate them in the same medium for 2 hours. Then, stimulate them with the bacterial endotoxin lipopolysaccharide, or LPS. 16 hours after stimulation, collect the cell-conditioned medium and use it to carry out Western blotting to measure the levels of HMGB1. Quantify the band intensity using a standard curve generated with purified HMGB1. To establish sepsis, after anesthetizing a mouse with an intramuscular injection of 75 mg per kilogram of ketamine and 20 mg per kilogram of xylazine, and using a toe pinch to check its level of sedation, place the mouse in a supine position. Clean the abdomen, then make a 15 mm midline incision to expose the cecum. Approximately 5 mm from the cecal tip, with a 4/0 silk suture, ligate the cecum, and then using a 22-gauge needle, puncture the ligated cecal stump once to allow extrusion of stool. Immediately return the cecum to its normal intra-abdominal position and close the abdomen. After animals regain consciousness and mobility, return the cage back to the animal room. At 24 hours post-CLP, intraperitoneally administer 200 microliters of herbal extract or control daily for 3 days. Monitor the animal for survival as long as needed. Within a few hours of cecal ligation and puncture, or CLP surgery, animals exhibit clinical signs of sepsis that include piloerection, lethargy, huddling, and a decrease in food and water intake. Animals developing severe peritonitis with consecutive systemic infection normally die within 48 to 96 hours. However, even age, sex, and genetic background matched animals can respond to the surgery in a distinguishable manner in the course of experimental sepsis. For example, At 48 hours post-CLP, while some animals may have approached the moribund state as defined here, others may remain at a non-moribund state. Comprehensive surveys of circulating cytokines revealed dramatic differences in levels of several cytokines, including IL-6, Kc, MIP2, and S-TNFR1, between mice in the moribund and non-moribund states. Notably, these inflammatory mediators have been classified as surrogate markers of sepsis because their circulating levels are reliable predictors of lethal outcome in experimental or clinical sepsis. In addition, CLP induced local release of various pro- and anti-inflammatory cytokines and chemokines. For example, at 48 hours post-CLP, significant amounts of the cytokine IL-6 and the chemokines Kc and MIP2 can still be measured not only systemically in the blood, but also locally in the peritoneal lavage fluid. Here, the capacities of various herbal extracts or control compounds were evaluated for their ability to inhibit endotoxin-induced HMGB1 release. Those that had the capacity to inhibit HMGB1 release were further tested in vivo using a mouse model of sepsis. Because of the late and prolonged kinetics of HMGB1 accumulation in experimental sepsis, the first dose of HMGB1 inhibitors was given 24 hours after the onset of sepsis, a time point when mice developed clear signs of sepsis including lethargy, diarrhea, and piloerection. As shown here, delayed and repeated administration of a major green tea component, epigallocatechin 3 gallate, or EGCG, beginning at 24 hours after onset of sepsis, significantly rescued mice from lethal sepsis. Even when given orally, EGCG still rescued mice from lethal sepsis, significantly increasing animal survival rates from 16% to 44%.
Once mastered, this cecal ligation and puncture model can be finished in less than 5 minutes if it's done properly.